So my topic is the Adnexal mass making a specific diagnosis. And so when we deal with a patient with adnexal masses, if we know the patient has a potential adnexal masses, ultrasound is a widely accepted first imaging modality, and you should do endovaginal ultrasound and color and power Doppler whenever possible. Now, of course, the reality also is that you're going to find incidental adnexal masses for an ultrasound that was done for some other purpose. But it has been shown for many years that expert sonographic interpretation, so in patients who have experience with reading these ultrasounds, is a highly accurate in differentiating between benign and potentially malignant masses that certainly has a high negative predictive value. So really our duty is, whenever possible, give a specific diagnosis. Don't just enjoy impression per se, heterogeneous adnexal mass. That doesn't help anybody. You really have to make a specific diagnosis if you can, and if you can't, put enough in your interpretation that you can guide further management. So in addition to the sonographic characteristic, what we also, of course, need to consider is the age and particularly the menopausal patient, status of the patient, whether this patient is pre or postmenopausal, whether there is a risk for ovarian cancer, Lynch syndrome, the BRCA gene, etc. The patient has any clinical symptoms, is she vaginal bleeding, does she have hirsutism, and of course lab abnormality, particularly CA125, which is a marker for ovarian carcinoma. So I'm going to talk about ORADs because one of the important things that it has achieved is, try to promote the use of a common language that helps improve communication with clinicians. So these are 3 different masses, 3 different diagnoses, and you do not want to say heterogeneous ovarian mass. You really want to describe them with precision so that you come up with a diagnosis. And of course, it's also helpful in guiding management. What's the next step in these patients? So I will then illustrate the key sonographic characteristics of benign lesions, discuss the role of ORADs, and see how we can offer appropriate recommendation. And the recommendation are multiple. Either you do nothing, or you get a follow-up ultrasound, or you need an MR, or a GYN referral. And if it's a GYN referral, is that a regular gynecologist that can do laparoscopic removal of the mass if we think it's benign, or does this patient we're worried about it, and does she need gynecological oncology? And so that's a different referral pattern. So all these things, I think, we need to try to put them in our interpretation. So these are the 2 articles from ORAS. The first one was published in 2020, and then there is another one just published in September 2023 in Radiology, where basically it's the same principle, but there are more specific ultrasound descriptors of certain lesions, particularly cystic lesions, and they have a little bit more specific management recommendations. And one of the goal again is to provide consistent interpretation and provide management recommendation for each risk category. And one thing I recommend is that you download the app. There is a phone app, whether on Android or iPhone. And if you search ORAS, you'll find this, and you'll see it's very, very easy to use. So you can get this as a quick reference. So I have it on my phone, for example. So what ORAS does is it goes from 5 category, from 0 to 5. 0 is when you can't see the ovaries, and with increases risk of malignancy, of course. And what it takes into consideration is the grayscale appearance of the mass, and they're very precise descriptor that you can read or look on your app, in addition to size, and in addition to a color score, which comes from 0 color score in this hemorrhagic cyst, to color 1, a little bit of flow, to 2 to 3. And of course, increased risk of, higher risk category with each increasing color. So I also think color is valuable in another setting. So these are 2 different patients. This was perhaps an older case, and this to me looks like an endometrioma. And it has, and we'll talk about why. But when I looked at this lesion quickly, I thought, maybe it's just an endometrioma as well. But, I went into the room and said, let's put color. And so the color is very different, right? In the endometrioma, the color is only peripheral, which it should be because endometrioma is a cystic lesion. But when I looked at this case, oh my God, no, this is inside the lesion. So it's not an endometrioma. It is a solid lesion, and it turned out to be a fibrothecoma. So if you're not sure whether a lesion is cystic or solid, color is extremely helpful. So MR plays a very important role. So we'll go in detail when it's indicated large masses. It's very helpful in indeterminate OVADs 3 and 4 ultrasound lesions because it increase your specificity. So if you look at the lesion like this, and I'll show you an example, these lesions look solid on ultrasound. I'm not sure. I mean, I think I have an idea, and I'll tell you why later what I think it is, but doing an MR really will increase my specificity in what this is. The role of CT really, I'm sorry, Dr. Fishman, but it's really limited to staging of ovarian cancer. CT is not very good at characterizing ovarian masses, except perhaps dermoid or an obvious malignant ovarian lesion. But it's only excellent in picking up the peritoneal carcinomatosis. That's very important for staging. So ORAD 0 is incomplete evaluation, and basically it depends, on what you're dealing with. It's incidental. The patient is an 80-year-old lady for, I don't know why they do a pelvic ultrasound. You don't see the ovaries. Okay. But if the patient comes for, palpable adnexal mass or something like that, and you don't see it, then you should put ORAD 0 because maybe this patient needs another examination like an MRI. ORADS 1 is normal. So, for example, usually they are premenopausal women, and it could be a dominant follicle, or it can be this corpus luteum, and the telltale sign of corpus luteum is really this ring-like peripheral vascularity. And I don't say ORADS 1 in my report, I just say normal. Right? We don't want to confuse people. Now, ORADS 2 are lesions that are almost certainly benign. So they have a risk of malignancy that's less than 1%. Now, typically, size will be taken into consideration in these categories. So the lesion should be less than 10 centimeters. And many times you can offer a specific diagnosis, and the menopausal status in some cases may influence management. So the most common is the ovarian cyst in a premenopausal woman. It can be a simple cyst, which usually is failure of follicle to involute, or it could be a hemorrhagic cyst like this one. And the term we use now, we used to use lace-like fishnet. The term that OVADs recommend now is a reticular pattern, as you can see here in this retracting clot. And they can be symptomatic, as we discussed on Monday. So this patient can present with pelvic pain. And of course, then you have your thecal uterine cysts, which are also functional cysts. And, we can recognize them. That's no big deal. Now, what do we do when you have a hemorrhagic cyst? And whether you see it on ultrasound or you see an ovarian cyst on CT, it's kind of similar rule. If it's 5 millimeter or smaller in a premenopausal woman with a classic appearance of a hemorrhagic cyst, they don't need a follow-up. If the cyst is more than 5 centimeters or is atypical, like this one, this looks like a echogenic lesion, right? It could be an endometrioma, could even be a solid mass for all I know. I mean, there was no flow inside, so but it doesn't look like a typical hemorrhagic cyst, so get a follow-up. And if you're going to get a follow-up, 6 to 12 weeks. So they fall in a different portion of their menstrual cycle. And this resolved after 4 weeks. They didn't listen to me, they did too early. But anyway, it got smaller. Now, what happens if it's a 76-year-old woman who has a cystic lesion? So it is recognized that as we do more and more vaginal ultrasound that we see, asymptomatic women with ovarian cysts. So to have a cyst, you want it to be unilocular in a postmenopausal woman. Unilocular, thin wall, no flow, or very, high resistance flow with no diastolic flow at the edge of the cyst. And we also know that's a bit more common in women who are on tamoxifen. So what is the management? So, check the CA125, make sure it's normal. If the cyst is less than 3 centimeters, the recommendation now is to do, nothing. If between 3 and 10 centimeters, like the 10 centimeters makes me a little nervous. So I probably would get a follow-up if the lesion is smaller than that. But anyway, these are the recommendations. You do 6 to 12 month follow-up for growth, and then yearly afterwards and we don't know for how long, but at least until, several years stability has been assured. And the natural history is that either they remain stable or they resolve over time. And of course, if the cyst enlarges or if there are mural nodule or thick septation appearing, then you're going to recommend surgery. Also, if the patient is anxious and is not able to get these follow-up ultrasounds. And some of the pathology that has been, shown in this when these postmenopausal simple cyst appearing lesion were found is serous or mucinous cyst adenoma, paraovarian cyst, or endometriosis cyst, or hydrosalpinx. Now, always when we talk about a cystic lesion, be very, very careful. Look at all the, because the clue here, the thing is that there has to be a simple cyst, right? So especially it's an older woman. So is this a nodule or what is it? So you can notice here that all these echoes are parallel to the near wall. So this is simply reverberation artifact. But we have to be careful and try to image this cyst in multiple plane to make sure that a small nodule is not hiding within the reverberation artifact. So this is a different patient, older woman also. So is this reverberation artifact? Well, this I'm not sure, but this cannot be, right? Because this has to be at right angle from the near wall. And this was a mural nodule. This patient had an elevated CA-125 and she had a, small ovarian cancer. Now, the next thing you can diagnose with certainty is endometrioma. So we talked about endometriosis in last lecture. This is basically functional endometrial tissue outside the uterus, and this time it's going to be on the ovary. So these are what you used to call the chocolate cyst. The cyst can be uni or multilocular, but there is an important diagnostic feature to recognize. So first of all, the term for these is either diffuse low-level echoes or ground glass appearance. And again, if you're not sure whether it's cystic or solid, just turn the color on and you shouldn't have no flow within this because this is basically all old blood that every time the patient has a new cycle, the endometrium will blood. The other things that are, I think, important to recognize is little echogenic foci with comet tail artifact within the wall. These are probably, debris from, degraded blood products. And sometimes, of course, they're not going to be as typical. They can mimic hemorrhagic cyst. So this is just a large endometrioma, which is multilocular, but one part, again, has this typical diffuse ground glass appearance. And of course, MR is excellent in making the diagnosis. They're bright on T1, and they have this T2 shading that's characteristic of endometriomas, and MR is also excellent to detect additional areas of deep pelvic endometriosis, which may be the cause of these patient symptoms anyway. So this is a very large endometrioma, again, diffuse low-level echoes. You see the little echogenic foci. But when we did the cineclip, and again, I highly recommend cineclips, there is, if you look between the uterus and the cyst, there is this hypoechoic band, and we could not separate the fundus from the cyst. And so that suggests to me that the patient has associated deep pelvic endometriosis. The patient had an MR. It was a large lesion anyway. So on the T2, you can see not only the endometrium with T2 shading, but the tethering of the uterine fundus near the cyst, again, suggesting that the patient has additional deep pelvic endometriosis, and this is confirmed on the laparoscopic with a big endometrioma here and then some nodules of deep pelvic endometriosis. Now, sometimes in pregnancy, they can look really weird because with progesterone, you can have dehydrogenation of endometrial stromal cells, and this will create sort of vascular, solid appearing nodule endometrioma, and it can really mimic endometrial ovarian cancer. So this was such an example. Here's a patient is pregnant and she has this really ugly kind of looking ovarian lesion, very solid appearing with increased vascularity. If you're lucky, the patient has had a previous ultrasound that showed an endometrioma. Otherwise, at least mention it in the report and let the gynecologist then deal with it. Because I have to say this is a scary lesion, but this turned out it resolved after the baby was delivered. This was a decidual endometrioma. So just something to keep in mind. Now, what about this case? That's another diagnosis we should make with certainty. So this is a 56-year-old woman who came in with breast cancer. She was coming to evaluate her endometrium, and long and behold, we found a 5-centimeter ovarian mass. And of course, she's going to be very anxious. She already has breast cancer. But if we analyze it, we see that this is cystic mass. It has these dots and echogenic line appearance throughout the lesion, and this is absolutely classic for the dermoid mesh in a cystic teratoma. So we can reassure the patient. And so these, are common ovarian neoplasm, usually in young adult, pregnant women, just because they're young women. However, as in this case, about 8 to 10% can be found in postmenopausal women. And they derive from all 3 germ layers. And and this was shown way back when, that if you have 2 of these features, you have 100% positive predictive value that this lesion is cystic teratoma. So what are these features? Dermoid mesh, I just showed you an example. Echogenic mass with shadowing. Dermoid plug, which is a lesion in the edge of the cyst with calcification or bone or fat. Or you can have a fat fluid level with floating echogenic balls at the fluid level. And again, so these are signs I'm looking for. So this is just a small, completely incidental, very echogenic mass. It's much more echogenic than the ovarian stroma. This is an incidental dermoid. I'm not sure we need to do anything about this. The danger with this type of lesion, which have been called the tip of the iceberg sign, is that it is very echogenic. It's kind of shadowing, so you don't see the posterior border. And in inexperienced hands, if your sonographer is inexperienced, they could confuse it with a loop of bowel. So that's just a word of caution here. They can be very large with a fat fluid level, floating hairball, and the dermoid nodule here. This confirmed on CT. There's bilateral dermoids. Now, what about this lesion? So this lesion is big. It's 14 centimeter. It's a young woman. You see an echogenic area with shadowing, but probably at this stage I would be a little nervous and say it's probably a cystic teratoma, but it's big. And the good thing about it is because it's over 10 centimeters, I get to recommend an MR anyway, because this will become an ORADS 3 lesion based on its size. Other lesion we can recognize is a hydrosalpinx, tubular structure with, you see the fimbriae or the septations. That's really easy to recognize. Or this lesion. So it's clearly separate from the ovary. It's a simple cyst, really easy diagnosis. And then this last one, which is peritoneal inclusion cyst, what happens is that in premenopausal women with active ovaries, the ovaries keep secreting some fluid, and because the patient had adhesions, either from prior surgery, pelvic inflammatory disease, or endometriosis, you have this cystic lesions, fluid which is trapped. It's usually surrounding the ovaries, so try to find the ovaries in the middle of this adnexal mass. Also, it has usually passive shape and doesn't create a mass effect. So in summary, these are the lesions we can diagnose with certainty. And again, you can go on your app and, just verify what you're describing. But simple or hemorrhagic cyst, endometrioma, cystic teratomas, postmenopausal cyst, para-ovarian cyst, hydrosalpinges, and peritoneal inclusion cyst. And in my report, I will put what I think it is, so I'll say consistent with cystic teratoma. So if your gynecologist want this, you can also add ORADS 2. But I think what is really important is you give a specific diagnosis, because you can. All right. Now, ORADS 3 lesions are lesions who have a relatively low risk of malignancy, probably less than 10%. And what do they include? So cystic teratomas or endometrioma that are more than 10 centimeters, multilocular cyst with, no or minimal color, or solid mass with some degree of shadowing with color score of 1 or 2. And these patients will usually should have further imaging with MR. And if they need to be taken out, a gynecology referral, but because we think they're likely benign, they can likely be treated laparoscopically unless they're huge, and also do not require gynecologic oncology consultation. So this is an example, a 17 centimeter mass It's simple cystic appearance on ultrasound, but there's no way you can be certain that there is not a little papillary projection hiding somewhere because the lesion is so big. And this turned out to be a serous cystadenoma. Now, this is similar to the first lesion I showed you. So this is a hypoechoic solid mass in the ovary. So it was not a fibroid, but kind of looks like one. There's some area of shadowing. That's important. And there is only minimal peripheral flow. So this would be an ORATS 3. I can say in my report, I suspect it's going to be a fibroma, but I wouldn't recommend an MR to make sure. And it is dark on T1, dark on T2 with kind of mild delayed enhancement. And it was verified at surgery that this was an ovarian fibroma. This is kind of a somewhat unusual lesion. We classified it ORATS 2 because we weren't sure what it was. It's a cystic lesion in a relatively young woman, but the septation's kind of thick. There's not much vascularity, but we sent her to MR. MR is kind of the same. We weren't exactly sure what it was. It turned out it was an atypical, again, regular gynecologist, turned out to be an unusual atypical cystic teratoma at surgery. Atypical in the sense of the imaging appearance. ORATS 4 is the next category. So these now we're getting more worried, right? This is intermediate risk. So it's 10 to about less than 50% risk of malignancy. So these are going to be your multilocular lesions or cysts with some solid components, but maybe less than 4, or solid mass, but no shadowing, and the color score in these lesions can be variable. All of these lesions will require, unless they're being taken out, an MRI and consultation with gynecologist oncologist this time, because we're not sure if they're malignant or not. So this was a 62-year-old woman with hirsutism, high testosterone level. So she has a solid mass, which is hypervascular with a lot of, kind of tumor type flow here with increased diastolic flow. Now she directly went to, so we still suggested the diagnosis of sertoli lytic tumor because it was a virilizing ovarian tumor, but of course she had to take her out. So she didn't have an MR because they were going to take it out anyway. Another couple of other lesions. This is a very large lesion, 23 centimeter, complex fluid, multiple septations, locules. Here it is on CT. You can see that it's, reaching the patient's liver almost. And this is a good appearance for a mucinous ovarian tumor. So again, I would suggest it in my report, but recommend some MR. And the majority, about 80% of these lesions, even despite their very large size, are benign. Another example, this was a young woman with abdominal pain. They suspected torsion. So we said, here there are multiple septations. There's probably even, is it a mural nodule? It's not very vascular. And she went to surgery because they were concerned about torsion. And this is another example of benign mucinous ovarian tumor. Now let's go to the last category, which is ORATS 5, high-risk patient, more than 50% risk of malignancy. So you're going to have your cystic lesion with mural irregularity or papillary projections, usually increased vascularity in the soft tissue part, but not always. Or it's a solid mass with color flow. Or if you see complex unexplained ascites, then this will fit in that category. So what are the features of invasive ovarian cancer? Well, it could be a predominantly solid hypervascular mass, or in this case, it could be a cystic mass with irregular nodules. The wall is not thin, and there are these mural nodules with, if we put color and we look at Doppler, there is increased disorganized vascularity with, increased diastolic flow, which suggests tumor vascularity, and also look for complex ascites. And this was a patient with endometrioid cancer. And again, you will see these features much better with transvaginal ultrasound than transabdominal ultrasound. Another example, 42-year-old woman, so relatively young to have an ovarian cancer, but they are now here. If you look quickly, you say, okay, she's young, maybe it's a dermoid, but because these are echogenic, but there's no shadowing, right? So if there's no shadowing at all, then you have to be really concerned. And this was a high-grade ovarian cancer in a 42-year-old woman. Or they can look like this. This patient came to the emergency department because she had abdominal distension, and they had ordered an abdominal ultrasound, not a pelvic ultrasound, but she had a lot of ascites, and her liver yet looked normal. So at this time, you could still do this. I called ED. I said, this patient is old. She has unexplained ascites. Her liver is not cirrhotic. Let us do a pelvic ultrasound. Now, that's what we did. And in the pelvis, she has this solid mass, very large, 9 centimeter solid mass, hypervascular, again with my, abnormal vascularity. And this was a fallopian tube adenocarcinoma. And this patient presented with just ascites. And this is her CT, again, showing the mass as well as, tumor deposits in the pelvis and complex ascites. So invasive ovarian cancer is not that common, usually affect older women. It peaked at about 50 to 60 years of age, but unfortunately it's the fourth leading cause of cancer death in women because many of these tumors, like the patient I just showed you, present late. These are silent tumors that will present late as an advanced stage. We know about the risk factor, BRCA gene, Lynch syndrome, etc. And the majority of surface epithelial tumors of the ovary, serous adenocarcinoma, mucinous cancer, although the benign type of mucinous tumor is more common, endometrioid and clear cell cancer. So what are the ancillary findings in ovarian cancer? So this is the same patient I showed you which had the solid mass. And so I'm going to look at the lining of the cul-de-sac here. This is complex ascites. If you have ascites, it will nicely kind of outline the outside of peritoneum. And here's this nodule. This is not part of the mass. This is separate. This is in the cul-de-sac. In this different patient, you have this complex cystic mass around the spleen. She had known ovarian cancer, so we thought this was a tumor deposit at the surface of the spleen. Of course, CT is excellent to demonstrate even not this subtle cases, even more, much more subtle than that, of peritoneal thickening and implants. Now, what about this patient? So she's 30 years old. She has a large adnexal mass. It's complex, and there are multiple nodules. There were more than 5. They're not very vascular, but still, so this qualifies as an ORATS 5. However, she's young. And so one of the things you think about, here's the MR, again, showing these enhancing nodules in this large cystic mass. And one of the things we have to at least think about in these young women with these large masses with papillary projection. Now, there's no ascites, there was nothing else to at least suggest the possibility this is a borderline serous tumor, because these are not that common. They can be serous. Usually they will have no stromal invasion. They're typically seen in younger women. 45% were younger than 40 in one series. And the reason why at least you mention them, because the gynecologists know they have a low malignant potential, that in this patient, doing the regular THBSO, treatment for ovarian cancer is probably not ideal because you want to think about their fertility. And so some of these patients have surgical resection of the tumor rather than more extensive surgery. And the survival rate is usually excellent. I want to complete my discussion talking about ovarian metastasis. They represent about 10% of malignant ovarian masses. The primary is usually, classically a stomach or breast, the so-called drop mets or Quickenberg tumor, but it should also be colorectal. We've seen this pancreas. We've seen with lung cancer. The clinical history is often the clue, and they can be bilateral. And this was a patient with this large mass. If you had no history, you would say this could be just a mucinous ovarian neoplasm, but the patient had a history of ovarian cancer, and she also had a liver metastasis. A brief word about ovarian sex cord tumors. I just show you a couple of examples. A sertoli Leidig tumor, which can be functional, a fibrotrichoma, and also granulosa cell tumors. So they can really have variable appearance. They can look solid, but some of the lesions, particularly granulosa cell tumor, like this large lesion, can be cystic and multilocular. And again, because of the degree of vascularity in the septation, you would call that an ORATS 5. Just a kind of fun case that was given to me by my friend Dr. Slovatsky. So this was a young woman that had this large pelvic mass, and you see that there is a solid component. But if you look at this, and I have another you can see maybe that she said, well, this has a lot of comet tail artifact. What's going on? And because she's brilliant, she said, well, I've seen this somewhere. Where else? In the thyroid. And so she actually suggested the diagnosis in this patient that this was a cystic teratoma with a lot of benign mature thyroid tissue that you will see once in a while. And to conclude, I mean, this looks for all the world like adnexal mass in this 88-year-old woman with abdominal pain. So she had a CT with its ovarian cancer. The ultrasound really didn't help. And it turned out, lucky for her, that it was ruptured appendicitis with an abscess. So in summary, I think what's really important is when you can offer specific diagnosis, use ORAS classification, because I think it will help you think in terms of describing it properly and also think about management. Because really what we need to do in our impression is, either say what it is if you can, or if you're not sure, give appropriate management, so that we really help our patient. And with that, I really thank you very much for your attention.